Hello everyone again. My name is Michael Levy. I'm an associate professor of neurology at Harvard Medical School and Massachusetts General Hospital. And I am doing this Facebook Live broadcast with support by the Sumaira Foundation and Viela Bio. I am just checking to make sure that technically everything is working. I'm going to go ahead and just check with my sponsors, make sure that this is working correctly. The way that I hope to conduct this 1-hour session is basically that I'm going to tell you everything I think for about the next 15 minutes or so, everything related to COVID-19 and NMO. And then after that, I'll take some questions from you all and answer them the best I can. Okay, so let's just start with what COVID-19 is. COVID-19 stands for, the CO is corona, the VI is virus, the D is disease. Coronavirus disease 2019, that's COVID-19. It was named by the World Health Organization recently, and it's different from SARS and MERS in the naming strategy because this was designed to help understand the difference between the virus and the disease. So COVID is the disease. The virus is the SARS-CoV-2 virus. Okay, it's very similar virus. This is something that arose from wildlife in China, probably bats, got transmitted to human by way of other animals in the meat market, and it quickly spread from there. The coronavirus is a very typical cold virus. So most of you have been exposed to coronavirus in the past, and it's extremely contagious. It's one of the most contagious viruses, kind of like the measles virus, very, very contagious, spreads very quickly. Just to give you an idea, if the flu virus, one person spreads it to an average of 1 to 2 people, coronavirus is spread from one person to an average of 3 to 4. It's just much more transmissible in that regard. Now, what distinguishes this COVID, the SARS-CoV-2 virus, from previous coronaviruses? The previous coronaviruses were not this lethal, okay? And there are many reasons that might be. The first experience that we had with this strain of coronavirus was the SARS virus, which, as many of you will recall, also originated from China and then quickly spread and proved how deadly that was. I think the fatality rate was on the order of 10% or so. And then we also had experience with the Middle East respiratory syndrome virus. Again, another coronavirus, very similar, except this one was transmitted through camels in the Middle East and had a fatality rate somewhere in the order of 40%, 40%. Very, very high. Now, this coronavirus, COVID-19, the fatality rate is somewhere between 1 and 3%. And the reason I'm hesitating is because what you really want to calculate is the number of deaths divided by the number who are infected. The problem is, at least in the United States, we don't really know how many are infected. There are certainly people who show up at the hospital and get the testing, and among those patients, about 30% will test positive for COVID nationwide. The other 70% have flu and everything else. But what about everybody who's staying home, who doesn't come in to get tested? I had some chills and stuffy nose a couple weeks ago, but I didn't even have access to get testing. Did I have COVID? I don't know. And so as long as we don't really know how many people in the U.S. have been exposed, we don't have a great way to measure the fatality rate. Um, of the 122,000 or so patients in the U.S. who've had COVID, there have been on the order of about 2,100 deaths. So the fatality rate is around 2% among those who have symptoms. So that, just to put that in perspective, is about 20 times more fatal than the influenza virus, the regular old flu. And so you have reason to be worried. This is an infection that is much more fatal than the flu virus. This is why following all the orders and the guidelines put out by your state makes sense. Because if you're sick, you want the infection to end with you. You want to quarantine yourself. You want to reduce the number of exposures that you have to other people, especially older, more vulnerable people. And you want that infection to end with you, if you can. Here's the problem with that strategy. The problem with that strategy is once you've felt like you have a fever and shortness of breath and a cough, once you have those symptoms, you might already have transmitted the virus for the past 14 days. It could take, you may emerge early. Some people get symptoms within 2 days of the infection. Some people get symptoms within 14 days of the infection. And so as long as you don't have symptoms, and that's basically all we ask you, is you have a fever, have you had a cough, shortness of breath? No? Okay, then you're fine. You might still be infected and might be transmitting the virus everywhere you go. Unless we have a policy where everybody is locked in their home, there's no way around that. I mean, we're just relying on people to maintain social distance, don't touch anything, try not to transmit the virus. Masks, which were previously looked down upon, like, oh, don't take up all the masks, you're depleting the healthcare providers of their opportunity to use a mask. The truth is, masks work, and they work to not only protect people from acquiring the infection, from particles that may be in the air, the virus only lasts a few seconds. But if people cough on you and it's in the air, then you don't want to get it. The other thing masks do is they keep you from touching your face. You might already notice I touched my face a couple times during this broadcast. Very hard not to do that. I acknowledge that. And so if you wear a mask, you often keep from touching your face because the mask is in the way. So these are the measures that we recommend to take to try to minimize the spread of the virus. But again, this is going to be a very difficult task. So far, the U.S. is on track to double the number of infections every 3 days. This is the trajectory that epidemiologists have been predicting. It's supposed to peak in different regions at different times. So in Massachusetts, where I am, we're expecting the peak this week. I don't know if New York is reaching its peak. I hope it is, because they have their share of cases already, and if they have any more, then that's a huge hurdle for them to be able to overcome. But as this virus spreads, we're expecting different peaks in different places of the country. And it may be that the hardest hit areas are the ones where people are crammed in the most. And if you use public transportation and you ride the subway, for example, can you imagine how easy it is to transmit a virus in a subway? It may be that the cities with public transportation are the ones that are hardest hit. We don't know. We really don't know right now. At the end of all of this pandemic, we'll be able to look back and say, okay, this is what facilitated transmission. This is what we could do next time to stop that. But in the meantime, everything that you can do to minimize your interaction with other people is really all we can recommend at this point. Now, who do we consider the most vulnerable? The most vulnerable people, clearly, the data shows this, are people over 60. And this means not only vulnerability in acquiring the infection. It's certainly true that people who have symptoms of the infection and test positive are much more likely to be in the older age group than in the younger age group. Now, does that mean that the younger age group are not getting infected? For sure, we don't know. But they're not being tested because they may not have symptoms. So it's certainly possible when we look back at all this that everybody in my age group and younger, that we're all exposed. Maybe my kids have had it. But we don't have a blood test of serology to confirm that we've been exposed to the virus and that we're immune to it now. So we just don't know. But what we do know is that older people are coming into the hospital, and I shouldn't say older. I guess if it's older than me, it's older, right? So 60 and older, 60 years of age and older, are the folks who we're most worried about. And it's worse as you get older and older. So those who are 80 and older are even more vulnerable than those who are between 70 and 80, and they're more vulnerable, than the people who are between 60 and 70. And if you look back at the data from China, the average age of a person hospitalized was 52. And so maybe we're not extending that warning to the younger age group enough. Maybe we should be saying if you're between 50 and 60, you should also be cautious. Now, it's not just who's getting infected, which is age is a risk factor for, but also the chance of dying from the infection. The older you are, the more likely you are to die from the infection. So age is definitely a risk factor. The second biggest risk factor that we're aware of is previous medical history that makes it more difficult for you to survive a pneumonia. And that would be, number one, lung disease. Number two, hypertension, and I'll explain why, and diabetes is the third. Those are the three biggest previous conditions that make it difficult for you to recover from a pneumonia of COVID-19. There are other medical conditions that also make it difficult. If you have neurological weakness that makes it difficult for you to cough or make it difficult for you to breathe under difficult conditions, that's a pre-existing condition that could make things worse for you. So you do want to be careful if you have a prior existing condition. Hypertension and diabetes may be related to certain proteins expressed in the lung that make the virus more transmissible. So when a virus enters one of your lung cells, it takes over the cell, makes millions of copies of itself, and then ruptures the cell, and then other cells near that area where you were first infected then become infected themselves. And the replication rate of this virus is unbelievable. I mean, if you look at the time it takes from a virus to infect a single cell till the time it's making millions and millions of copies and just coming out of your mouth with every time you sneeze or cough, it just takes a few hours. Within a few hours, you're already making millions and millions of copies. That's how effective this virus is at taking over your lung cells. So those are your prior medical conditions and age. Now, what about immune compromised state? I realize I'm talking to a group of NMO patients here. On the CDC website, you will see that immunocompromised state is on the list of risk factors. It's low down, but it's on there. And they put it on there because rationally, it makes sense. If you suppress the immune system, you make it easier for the virus to invade your body. You might even prolong how long it takes to fight off the infection. But is that actually the case? Well, we don't have enough data at this point to confirm it. We didn't have enough data from MERS. We don't have enough data from SARS. And COVID-19, we're still trying to gather that data. I could tell you anecdotally, we're reaching out to my colleagues in China and Italy and other places, what we're hearing is that immune-compromised state may not be the biggest risk factor. Certainly age, prior medical conditions, everybody agrees on. But immunocompromised state, there are transplant groups that are worried about it, cancer patients who are immune suppressed, lots of different people who are immune suppressed, but those do not seem to be the folks who are dying from the illness. Now, it certainly may be a risk factor to getting infected, but again, we don't have that risk, we don't have that data, so we're going based on rationale. The rationale is you're more likely to get infected, you're more likely to have a prolonged course, but we don't have any data right now that you're more likely to die from your illness. We do have some encouraging information on the end of the disease spectrum on the mortality end. It seems that once you hit the ICU and that infection is roaring, that it creates what's called a cytokine storm, which is where it triggers your immune system to just go into complete overdrive, try to defeat this virus. And actually that immune response is more harmful than the infection itself and can lead to death. And so recognizing that, there are several trials that have been launched now to quell the immune response a little bit. So yes, you might prolong the infection, but on the other hand, you're saving someone's life by keeping their immune system calm and fighting it in a steady way rather than in an overwhelming way. And the medications, interestingly enough, that are being used to suppress the immune system for COVID-19 are the same ones that you are on now. Eculizumab is in trial, that's Soliris. Mycophenolate is in a trial, that's Cellcept. Prednisone is in a trial, those are steroids. And tocilizumab, which is the parent compound for satralizumab, which was tested in NMO. So those 4 trials are ongoing. Rituximab is not, that I've seen, not in a trial, and we can talk about why that is. But that might be a little bit of reassurance to you that if you're immune suppressed, yes, you might be more likely to get the infection, you might be have more prolonged course, but hopefully in the end it'll provide you some protection against the fatal consequences of the infection. Okay, I'm going to take a couple of questions from the audience. Let me see if, okay. Is there a difference from using a painter's mask or a regular blue mask? This is a great question. The efficacy of a mask depends on what you're trying to achieve. When people don those surgical masks, the only thing that does is it keeps you, the person who's infected, from infecting everybody else. So you're doing a good deed to society when you put on a surgical mask, assuming that you are sick, because you are keeping your own virus tucked within you. That is the best reason to wear a surgical mask. It's not that effective in keeping other viruses and organisms from getting in you. And so if all you have is a surgical mask, if all you have is a handkerchief, you're doing something. There is a barrier there. How effective is the barrier? Not that effective. They say on the order of about 70% as effective as an N95 mask. So if you try to get an N95 mask on Amazon, good luck. I mean, they're in short supply and they're difficult to get. Let's say you're going to a infusion center to get your Rituximab, which is something that we're going to address. What kind of mask do you need to wear? I'd say get an N95 mask. Get it from the hospital when you show up. Trade out your surgical mask if you have one for an N95 mask because that's the best way to protect yourself when you're in a high-risk environment. All right, let's see. We've got other questions here. What about open heart surgery? Open heart surgery is a temporary immune compromised state. So during the time that you're getting your surgery and immediately post surgically, you are immune compromised. And shortly after you emerge from surgery, you should be recovering fairly quickly. The immune compromised state after open heart surgery is not your problem now. The problem after open heart surgery is that you had to have open heart surgery because you have heart disease. Heart disease is also one of the risk factors for having a bad outcome after COVID infection. So open heart surgery, heart disease, all those things, high risk. So if you think you might have the infection, do not go around anyone with open heart surgery. You're not doing them a favor. You might transmit the virus to them, and then they may have a worse outcome. Okay, let's see. Here's a patient who says, chronically infected with Pseudomonas, which is very well controlled. Looks like tobramycin. How could that impact the disease course? All right, so one of the concerns is that when you have a COVID infection, you might actually acquire a secondary infection. That's very common. For those of you who had fever for 2 weeks and you're coughing and suddenly it gets a lot worse, that's a superinfection. It's usually bacteria on top of virus. Now, what you're asking is you actually have a bacterial infection first. Can you get a viral infection on top of that? Yeah. So basically, anytime you're not clearing your mucus very well, and things may get stuck in the mucus, and you may contract it that way. Absolutely. So anything that increases your risk of an infection, certainly a Pseudomonas infection would do that. Puts you at higher risk. Let's see. There are questions about other symptoms. Diarrhea, definitely not. So if diarrhea is your main symptom, you're probably not COVID. Doesn't mean that you don't have an infection. It just means it's probably not the coronavirus. So that would be good. Other questions? Let's see. Okay, so I have NMOSD and lupus. I've been on Plaquenil and Rituximab for years. My last Rituximab was March 5th. So you're set for Rituximab for a while. Feel pretty isolated on my own. If I feel symptoms from a flu coming on, can I bump my dosage daily to help with my symptoms? I assume you mean of the Plaquenil. The mechanism of Plaquenil is not well understood. It has been touted to be a treatment for COVID-19. One of the mechanisms that it's thought to work by is that protein that I told you about in the lung that is an anchor for the virus. This medication is thought to downregulate that. Actually, diabetes makes it go up. A certain medication that we use for hypertension called ACE inhibitors makes it go up as well. And so that's why those risk factors are worse for COVID-19, and Plaquenil seems to be better. Now, if you're already infected, does it still make sense to take it? Yeah, because every time one of your lung cells ruptures open and releases millions of viruses back into your lung, those viruses infect uninfected cells through that same protein. So it does make sense. There is the dosage for COVID-19 is a little bit higher than the dosage for lupus, but it can also be dangerous. And so you really, if you have access to your rheumatologist who prescribed the Plaquenil, I would discuss that dosage with them. Make sure that it's the right decision for you in terms of the balance of risks with side effects. And I will say that there are studies to be done with Plaquenil. I don't think that that's one that Anthony Fauci of the NIAID at the NIH has jumped on board with. I think that there are other trials that he's interested in, and we'll just have to wait and see when the data is released. Okay, question about history of asthma and working at home. Or trying to avoid people while working. Absolutely, asthma is one of the risk factors. Any prior lung disease, you don't want to take any chances, especially if you're older than me. Then you don't want to take any chances. Try to avoid people as much as you can. Okay, what about getting tested? So testing is a state-by-state ruling. So in Massachusetts, for example, to get tested, you have to have symptoms. It has to be either fever, shortness of breath, or cough. It has to be persistent. It can't just be that it started that morning. And you have to have a high-risk criterion. You have to meet at least one. Immune-compromised state counts. If you got Rituxan, prednisone, Celsin, whatever, and you're immune-compromised, you qualify in Massachusetts. So check your state medical board or Department of Health website. Find out how you qualify. There are some states that don't have qualifications, and everybody's allowed to get it, so you can check into that too. Okay, Rituximab and treatments for NMO in general. Let me just say this. It's much, much more dangerous to stop or change your treatment. It's much, much more dangerous for your NMO to do that than the risk imposed by COVID-19 on you, unless you're 70, 80 years old and in the hospital infected, and that's a very small group. So for all the rest of you out there who are thinking, should I change my medication? Should I reduce my dose? Should I delay my Rituximab? The answer is no. No, no, no. Because imagine what would happen if you ended up with a relapse and then you had to go to a hospital where everybody's coughing up their COVID-19. So then you're in the hospital with a relapse, breathing in all that virus. You don't need that. What you want to do is get your treatment. If you're on Rituximab, get it at an infusion center, maybe away from the hospital. They have private infusion centers. We're still a little bit leery about doing Rituximab at home given all the infusion-related reactions. So call an infusion center by you that's not directly linked to the hospital building. Try to find one that's a little bit off-site. That would be the best. If you're getting Eculizumab or something else and you're doing that at home, great. IVIG at home, great. Rituximab and Ocrelizumab, get it in an infusion center, but go. And here's the precautions you should take. When you get to the infusion center, sit in your car until they're ready for you. Do not sit in the waiting room. Don't sit anywhere until you get to your hospital chair. Don't touch anything. Wear gloves, wear a mask, don't touch the pen. Bring your own pen. Don't touch anything. The way I say it is, treat it like you're in the bathroom at Fenway Park. Don't touch a thing. Just do what you got to do and then get out of there. But you need to get your medication and then you need to get out. Okay, what role does IVIG play in protecting the immune system, especially the immune compromised? Great question. This particular virus has no immunity anywhere in the world. Nobody's been exposed to this virus yet as far as we know, so nobody can provide you extra protection, which might be found in IVIG. So the way IVIG was developed was people who had decreased immune systems would get antibodies from the community to help fight off an infection. In this case, nobody else has fought off coronavirus yet. And so the IVIG that's been prepared over the past couple of years is not going to provide you any increased benefit. If you have a superinfection, sure, it might help with that infection, but it's not going to help you with coronavirus. Now, what they are doing is they're collecting, there's a trial to take serum from people who've been exposed and who've recovered well, because you know those people are making antibody to coronavirus, trying to bank those antibodies and provide them as an anti-serum for patients who need them. Okay, question about other medical procedures during this time. If it's elective, defer it. Wait until this pandemic is over. Now, what are elective surgeries? Plastic surgery, anything like that. If you can stand on that hip or knee instead of getting it replaced, if you can wait a little bit longer, wait. If you can't wait, you can't wait. You have to have cancer surgery, you can't wait. The question here is thyroid removal. It depends if it's a cancerous node, if it's causing more harm than the risk of acquiring a coronavirus infection, you got to do it. And so talk to your doctor. The way we classify things in the hospital is essential or non-essential. All non-essential things, wait. Essential things, you got to do them. You got to get it done. You take maximum precautions. You're not going to get any visitors in the hospital while you're undergoing whatever treatment, but you got to get it done and then get out of the hospital. Dr. Levy, my son gets IVIG weekly. Do you foresee antibodies to COVID-19 showing up in future batches? Yes. But amazingly enough, we don't even have a serum antibody test for COVID-19. Hopefully we will very soon, though. Okay. What about MRIs? Should you get MRIs? No, unless you absolutely need it. If there's a question about some new weakness, new numbness, new bowel bladder pumps, that's much different from your older ones and you really need an MRI, okay, that becomes essential. Then you go and you got to do it, get it done, wear a mask, don't touch anything. If you don't really need the MRI and you're getting a routine study, wait, just defer that. Methotrexate scheduled for parathyroid, potential thyroid removal. Again, call your doctor, say, is this essential? Am I going to get a lot worse? Is this potentially cancer? Do I need to get this out? Am I going to feel worse if I wait, 2, 3, 4, 5 weeks? Am I putting myself in worse harm than the risk of getting the infection? If the doctor says, yeah, you really got to get this thing out, then just go do it. Do I recommend continuing rituximab treatments? Yes. Absolutely. There's still no indications that rituximab patients are at even higher risk whatsoever. Now let me explain something about rituximab. When you get your rituximab, you get it IV. And the rituximab stays in the bloodstream. It has very little penetration to lymph nodes, bone marrow, or other tissues. A little bit gets out, but most of it stays in the blood. And that means that most of its target are the B cells in the bloodstream. And when you look at where your B cells are, you only have about 5% in your blood. The other 95% of your B cells are outside of the blood, and lymph organs and circulating, doing what they got to do, but outside of the bloodstream. So when you deplete those B cells out of your blood, you get the full benefit for NMO. Your NMO goes into remission. And you don't have to worry about the other 95% of your B cells. They're not contributing to NMO relapses, and they are continuing to fight infections and fight cancers and do what they have to do. So NMO patients who are on Rituximab, you have B cells in your respiratory mucosa. You have them in your tear, not in your tears, but in your eyes and the tissue in your face and your sinuses. They're all there. They're fighting the infection. They can do their job. The only place where your B cells are not, they're not in your bloodstream. Now, what would that do if you got COVID-19 directly into your bloodstream? I don't know. I haven't heard in any cases like that, but so far, we just go by data. Haven't had any cases so far to be concerned about. You have B cells in your lungs. If you're on Rituximab, those B cells are still there, fighting infection, doing what they have to do. So don't be too concerned if you're on Rituximab. It's a very selective type of treatment, maybe too selective even to be helpful in COVID infections. That's why they're not even bothering to test for Rituximab, because it really only depletes B cells in the bloodstream. COVID-19 infection is not directly in the bloodstream, it's everywhere. And so it might not even be that helpful for treatment of COVID infections. Okay, let's see. So what if you get infected? This has been a matter of debate between our immunology group and our infectious disease group in the hospital. Let's say you have a patient who comes in and they have fever, cough, shortness of breath, test positive for COVID-19, and they're on an immune suppressive drug. What do we do at that point? That's a very difficult question to answer. It's going to be an individualized decision, because if you're doing somewhat okay and you can breathe and maybe you're on a oxygen nasal cannula and you're not intubated and you're managing your secretions, you're doing fine, then you stay on your immune suppression, because the last thing you want is for that infection to trigger a relapse. So you got to balance all the risks, and that's the best way we know to balance it. And that's true regardless of the infection. So if you have an infection in 3 months from now, urinary tract infection or some other viral infection that's going to spread around, we say stay on your treatment, go to the hospital, get treated for your infection. Same is pretty much true for coronavirus. Now, what if you end up in the ICU on a ventilator fighting for your life? Again, these treatments are double-edged sword. They may have put you in the ICU, they may have made it more likely to get the infection and made it harder to clear the infection, but they may also be saving your life by preventing that overwhelming immune response. Rituximab maybe not so much, but the other drugs seem to keep your immune system from becoming the problem instead of being the help that it needs to be. Okay, let's see. Okay, what about, insurance coverage? This is going to be a huge problem. So people are switching to telemedicine visits, they're getting infusions at home. Are they covering that? Medicare, for example, never covers home care. So half of our patients with NMO around the country are on Medicare and Medicaid. Are their treatments going to be covered at home for IVIG, for example? And the answer was no, until this new bill going in front of Congress trying to make things a little bit more feasible while we get our act together with COVID-19. Plus, a lot of insurance companies are being a little bit more flexible now with coverage. I'd say do what you have to do. It's always better to ask for forgiveness than to ask for permission. So do what you need to do first. Get the infusion in the setting that you want to get the infusion that's best for your health, and then fight the insurance company after the fact. I think you'll have a lot more success that way than taking your chances the other way around. Okay, infusion doc just called. Said nurses are wearing N95 masks and families are wearing regular masks. She said my daughter is too high risk to have Rituxan at home. That is true. We don't want Rituximab at home. 80% chance of infusion-related reactions with Rituximab. We don't want to take that chance. So we want you in an observed setting. We want you getting your vital signs checked all the time. We want to have a crash cart there with epinephrine and steroids and everything that we need just in case you have an infusion-related reaction. So do that in a observed setting rather than at home. Absolutely. Okay, Imuran for COVID. I do believe that there is a study looking at Imuran in COVID as well. Imuran, methotrexate, and mycophenolate all affect the same pathway involved in white blood cell proliferation. These are this immune cell proliferation. So how fast they divide and the metabolism of these cells are all targeted by mycophenolate, Imuran, and methotrexate. So that mechanism is being investigated. What about vitamin C? Vitamin C is thought to reduce that protein in the lung I told you about. That's an anchor for that virus. Definitely load up on vitamin C. Take a gram a day if you can. It's a water-soluble vitamin, so no matter how much you take, you can't really overdose on it. So zinc, I don't know. I haven't heard anything about zinc. Can it be harmful? I don't think so. Just take what's on the bottle for a few days, and hopefully that would help as well. Okay, what about complying with the 6-foot social distancing? The 6-foot rule came about because if somebody coughs or sneezes, generally if you're within 6 feet, you can detect the virus on a droplet. And if you're more than 6 feet away, those droplets can't reach you. And so that's why you want to stay 6 feet away. That might become something we adopt as a country, even after this, because it's not just this pandemic, but it's every bug pretty much. But once you cough or sneeze, if you're 6 feet away, your chance of getting that infection right there and then, much, much, much lower. So definitely social distance. Okay, now what about spouses? So let's say you're the immune compromised person and you have a spouse who works at, I just came from our recreation or our motor vehicle place in Massachusetts, getting license plates for my cars. Those people are all at work. They're all wearing gloves and masks and everything, but are they likely to bring something home to their spouses from interacting with all of us in the public? Chances are they're at higher risk, yeah. So what do you do to avoid that? There are people who recommend sectioning off parts of your home to try to accommodate this, right? Because otherwise, the only other option is to keep your spouse at home, which is loss of income. That could be even more difficult. So if you can separate from the person who's working and just try to keep them separate, and this is very important if you have an older person at home, definitely try to keep that person away. Because like I said, immune compromised state, yeah, it's on the list of risk factors, but not as much as being older. So if you have somebody 70s and 80s at home, and that person is exposed to the person who's working every day, that's much higher risk than if you're being exposed to your loved one every day. Okay, what about public places? So you got to get to the grocery store. You got to do other things that you have to do. Go to those places, do what you have to do, take all the precautions. So if you have gloves, great. If you have a mask, great. If not, put a handkerchief on. Ask your loved one to wash their hands when they get home. So if they just handled all the groceries, spray the groceries down, ask your loved one to wash their hands, and then that reduces the risk of transmitting something coming from the grocery store. Okay, now let's see. Do you foresee the potential vaccine to be available but safe? Yeah. The vaccine that's being tested for COVID-19 is based on that protein that anchors to your lung. And that protein is being synthesized in the lab. So it's a synthetic, it's called recombinant protein, which is the safest type of vaccine. So it's not going to be the virus. It's not going to be a live virus. It's not going to be an attenuated or a crushed up virus. This is a viral protein. So that's about as safe as it gets. When you create a vaccine, you put that protein in with what's called an adjuvant. The adjuvant is a chemical that stimulates the immune system. Because the idea is you want to stimulate the immune system and only in response to that protein. But of course, when you stimulate the immune system, you may get a wider stimulation than you were hoping for, rather than just stimulation to that one viral protein. So the adjuvant is always what puts people at risk. And the adjuvants have to be tested, and adjuvants have come and gone over the years. You may recall there were adjuvants that had mercury in them a long time ago. Those have been discontinued. The adjuvants these days are about as safe as we know how to make them. And hopefully they will be using safe adjuvants with this protein that would be effective and the safest option. Okay, can a COVID infection trigger a flare? Chances are that it can, just like any infection, but if you're on treatment, that chance is much, much lower. So if you have a COVID infection and you're on Cellcept, mycophenolate, or you're on Rituximab or whatever you're on, stay on that treatment because that's hopefully preventing your disease from relapsing. So you definitely want to do that. Okay, here's a patient who has NMO and an unspecified lung disease with diet-controlled diabetes, but still diabetes, on oxygen, with a urinary catheter, so that remains there 24/7, and on a small dose of prednisone. And you're 68 years old. So yeah, that's pretty much, you've checked off every risk factor. You're the person that I worry about the most. Whoever sent me that message, please do take all the precautions. You're the one I would worry about the most. Okay. What about, there's more questions about postponing infusions to keep out of the hospital. If your only place to get the infusion is in the hospital, go get the infusion. Get it done. Like I said, gown up, cover up, get the mask on, get your gloves on, don't touch anything, wash your hands, you get in and out, do everything you have to do, and don't sit down, don't touch anything, don't touch their pens, just get in, get the infusion, and get out. Do that because that's the only way we know now to prevent a relapse from occurring. And once you have a relapse, you're going to end up back in that same hospital with all the virus around you, but you're going to be there for a lot longer. So definitely, even if the only place you can get your rituximab is in the hospital, plan for it. Stay in the car until it's your turn. Don't sit in the waiting room. Get in, get out. Don't forget to wash your hands. Don't touch your face. I've already touched my face half a dozen times in the middle of this presentation, so I understand how difficult it is not to touch your face. Okay, what about other medications, such as those used for neuropathy, pain management, things like that? As far as we know, there's no interaction, no increased risk factors that we know of. The one exception, you may have seen this on social media and other places, is ibuprofen. Ibuprofen does increase expression of that protein that anchors the virus. Do we know for sure that it makes things worse? We don't know for sure, but why take the chance? If you have access to Tylenol or naproxen at home, that's a leave. Naproxen is a leave. Use that instead of ibuprofen if you can. Okay, what about antibiotics and Cellcept? Does this leave you more susceptible to the virus? No. If you're on antibiotics for a bacterial infection, you're not more susceptible. Cellcept, yeah, again, suppresses your immune system. Rationally, it makes sense. We haven't seen any numbers that suggest that mycophenolate is actually suppressive. And remember, should you get the infection, that mycophenolate might help to prevent an overwhelming immune response, might keep you out of the ICU. Okay, what about pediatric patients? Pediatric patients, as you know, are rarely ever symptomatic, hardly ever. But there are some kids who don't do well. There was one neonate, blanking on the state, maybe it was Ohio or Toronto, who died of coronavirus. And so they're not immune to coronavirus infection. It's just that they're much, much less likely to get sick. And what about a pediatric patient on immune suppression? Now, you're talking about rare of the rare, and we just don't have the data, but I think they're about in the same category as young patients in general. And so hopefully we're not going to hear about any more cases like that, because as far as we know so far, it seems like even if you have a kid and they're on rituximab, they should be okay. A child on IVIG, even better, because IVIG is not immune suppressive. It's immune boosting, if anything, and so that might be the safest of all the treatments. A child on mycophenolate may be a little bit immune suppressive, but has the benefit of being young. So again, children in general, we're a little bit more relaxed about than somebody who's over 60. What about people who have suppressed immunoglobulin levels, IgG levels, as a result of chronic rituximab use, or for whatever other reason, if your IgG levels are low? Should you boost your immune system with IVIG? Would that be helpful at all? Probably not. Because like I said, COVID is not yet part of the general population. We're not seeing COVID-19 antibodies. It's probably not in the IVIG product, which has been packaged months ago. So it's probably not going to help you fight a COVID infection. Can it help you fight a different infection? Sure, maybe. So if your antibody levels are low, you're getting recurrent pneumonias, and you don't want a pneumonia in this context, IVIG might help in that in that regard, yes. Are there any NMO patients who've contracted the COVID virus? Amazingly, not a single one that I know of. And at first I just thought, well, maybe it's just that only 1 in 1,000 Americans have been infected, or even less. Maybe it's just a numbers game. So I contacted my colleagues in China, and I said, in Shanghai and in Beijing, and I said, how many patients have you had, of your patients with MS or neuromyelitis optica, how many have had the infection? Out of 1,400 patients in these combined centers, 0. Now, why is that? The immune suppression? Probably not. Again, it may just be numbers. I'm not saying that NMO is in any way protective. Neither is MS. Again, it may just be stochastic. It may be the numbers game. Maybe the NMO and MS patients in general are younger, maybe, but we just don't know. So far none that I know of, but if you had COVID infection and you're on Facebook, please speak up. I'd love to hear from patients. Okay, now what point should you seek medical care if you think you have COVID-19? So if you have a fever, and you have shortness of breath, or any other respiratory infection symptoms, first thing you do, call your primary care doctor. Primary care doctor is going to ask you a series of questions to see if you're eligible for COVID-19 testing. There are ways of getting testing that really minimize your risk. So there are drive-through clinics where you literally keep your windows closed in your car, you drive in, then you lower your window, they swab your tonsils, and then you're out of here. And you drive away, and a week later they call you. It's pretty low risk. A lot of it is access to testing in terms of who will allow you to do that. I know that there are some states where it's easier to get, some states where it's harder to get, so you just have to call your primary care doctor, check in with them, and see what you have to do. If you have neurological symptoms as well, then you want to call your NMO doctor and say, do you think this could be a relapse? Do I need to get this addressed right away? Or do you think this is more likely related to an infection that's just bringing out neurological symptoms? So neurological symptoms, call your neurologist also. If it's just fever, sore throat, shortness of breath, first thing you do, call your primary care doctor, find out where to go get tested. Okay, let's see. Is there a better filter for infusions? I'm not really sure about filters on infusions. I don't think there's any chance of getting a viral infection directly transmitted intravenously. I'm not sure if that's the question, but if you can, please rephrase your question. Let me know if I addressed that. Okay. What about risks of an infusion center away from the hospital? Is that as high risk as a hospital? Definitely not as high risk as a hospital. The hospital is where all the COVID infections are right now. And if you have respiratory infections and a high fever and a cough, that's where you'll end up. You're not going to the infusion center. So the infusion center should be lower risk. Now, if you need to go into the hospital to get to your infusion center, you're exposing yourself. If there's a way to get to the infusion center not by going into the hospital building, that's always better. So if there's a different entrance, if the building is off-site or somewhere else, that's always better than having to walk into a hospital and expose yourself to virus unnecessarily. Okay, symptoms of the MS hug. So this is that transverse myelitis symptom, squeezing, burning, or otherwise painful sensation around the trunk. It could be one side, it could be both sides. Does that make things worse with COVID-19? No, it does not. Those symptoms are entirely caused by damage in the spinal cord, and those symptoms that you feel are not actually due to any damage in the lung. So what the virus is seeing and what you're feeling would be completely separated. Now, what if you have spasms in your chest that keep you from breathing? That might impair your function a little bit. So if you can't breathe normally and you can't clear your secretions, make things go in and out normally, can't clear mucus or other your saliva, then you might be at risk. So people who can't swallow well, people can't breathe well, because of weakness from an NMO attack, might be at higher risk. That's that background neurological disease that may make you at higher risk. Okay, how high of a temperature should you be worried about? It doesn't have to be high. So coronavirus does not notoriously cause high fevers. It's usually a temperature of 100 degrees. So that's, some people don't even call their doctor for that. But that is a fever. Anything 38 degrees Celsius or 100.4 would be considered a fever. If you're in the low hundreds, I would call. That counts. Long-term shortage of Plaquenil. I do think people might be asking for this. We're being instructed not to dispense it until that there are studies to support it, or that they're using it in the hospital. But we're not routinely prescribing Plaquenil for our patients. So if you call me and you say, "Hey, can I have Plaquenil just in case?" I'm going to say no, because we don't know how to use it. We think the toxicity might be worse than the treatment. There are all kinds of monitoring issues. It can cause eye problems. Or you don't want to take Plaquenil until you know you need it, or until there's data that the benefits outweigh the risk. Okay, let's see. There's a question about pressure ulcer surgery. So pressure ulcers are the type of tissue damage from laying down or sitting down too long on one part of your body, and infections brewing there and making it hard to clear. Whether you should get that treated or not, I would talk to your doctor. That's a borderline case, because you don't want to live with those kind of infections too long. You don't want them to get worse. So that might be an essential surgery, in which case, gown up and do what you got to do, and then get out of the hospital as quickly as you can. Question about other lung diseases. So if you've had a pulmonary embolus in the past, if it's caused lung damage, you're at underlying risk, because areas of lung damage can harbor infections, can make it hard to clear mucus from that area, and that might brew and cause pneumonia. So yes, if you have any lung damage, you're at higher risk. Question about a ground glass nodule on an MRI seen 6 months ago. Call your doctor. If they're really worried about it, they're worried that may be a brewing infection, pneumonitis of cancer or something else, call and say, do I need this? Is this essential? Use that word essential. And if they say, well, that can wait a few months, then wait. If they say, I don't really like that sitting around in your lung, then gown up, get it checked out, wash your hands when you go in and out. Do you think at some point it won't be safe for me to get my Hizentra every other week sub-Q? If you're getting it at home and you're doing fine with it, there's no reason not to continue it. That should be fine to continue at home as long as you need. Treatments for superinfection. It depends on the bug. So there are some bugs, like someone mentioned earlier on, Pseudomonas. It's usually treated with 2 antibiotics. It just needs broader coverage. There's some bacteria that have acquired resistant strains now. So you need to ask your doctor and say, am I on the right antibiotic for this superinfection? You need to be sure you're on the right treatment for the right infection. How do you know if you have a superinfection? Sometimes you don't, but the typical course is you're kind of going along with one set of symptoms and suddenly you get a lot worse. And then that's what we call the superinfection. That might be treatable with a different course of treatment, like an antibiotic, assuming it's bacterial. Do you foresee for the immunocompromised being quarantined longer than the general population? If being immunocompromised turns out to be a risk factor for COVID-19, then yes, I do. Because what happens after everyone goes back to work is we're going to see a secondary infection. Because everybody who's been hunkered down is now going to start mingling again, and the virus is going to start spreading again, and all the people who are out and about are going to be, for the most part, the folks who can handle it. Then they'll be bringing it home, and then we'll see a spike of secondary infections in people who are vulnerable. So yes, I do believe if you're immune compromised, you need to take extra precautions, even beyond the time that that your state relaxes all the going back to work rules. Should those who have who are immune suppressed or have other issues self-isolate longer? Yes. Again, I do think that you need to be even more cautious. Word of hope is that the vaccine therapies have already launched. There are several. I think that I heard about 20 different vaccines that are going to be tested. Some have already started, and that hopefully the most optimistic timeline that I've heard so far is a vaccine potentially by June. Do not hold me to that, but we'd love to see that. and then once you get the vaccine, that's great. Or if we have a serology test that determines whether or not you've been exposed in the past, get that. It's very possible you've already been exposed, fought it off, never had any symptoms. Then you can go out in the general population and provide herd immunity to the rest of the people who haven't been exposed. So we're either one of those, either the serology test or the vaccine, and then you're going to be great. Any extra precautions to take with my trach? So trach is a device that helps people access either a ventilator or room air for people who can't control their secretions by mouth. Yes, that is a risk factor because it's difficult to control secretions. For whoever asked me that is a risk factor. Do be careful. Does Soliris hang around blood vessels and suppress complement similar to Rituximab? Soliris blocks complement, yes, but fortunately Soliris does not interact with this COVID virus. So the virus, the part of your immune system that fights off the virus has nothing to do with the complement system. So you're going to be fine. In fact, Soliris is being tested to prevent the overwhelming immune response that causes ICU and ICU level issues and death. So Soliris is actually being tested as a treatment. So if you're on Soliris, stay on Soliris. It's not hurting you. If you get infected with COVID-19, stay on Soliris. Go to the hospital, get your treatment, stay on Soliris the whole time. Let's see. Higher chance of being infected while on CellCept? Maybe. Higher chance of being infected, longer duration of disease, but hopefully a protection from that overwhelming immune response so you don't have the cytokine storm at the end. Are you immune compromised on Rituximab? That's always been a question. Rituximab is such a selective therapy. The question of whether or not it actually suppresses your immune system per se, makes you more likely to get infections. Part of your immune system is suppressed, and certainly there are there's an increased incidence of zoster virus, for example. So if you've had chickenpox, you can get these zoster reactivations. Rituximab makes that more likely. Hepatitis B virus, same thing. So Rituximab is immune suppressive to some viruses. With COVID-19, we don't quite know yet. Patients going to the hospital for treatments. If you gotta go, you gotta go. Just like I said, suit up, put a mask, put on gloves, wash your hands after you're done. Don't touch anything. And if you have to go to the hospital, then you need to go. Okay. If you are immune compromised and you get COVID-19, you test positive, do you need to end up at the hospital? Not necessarily. You can stay at home. In fact, being at home might be even better. There are a lot of infections circulating around in hospitals. If you can stay away from the hospital, that's even better. So how do you know when you need to go into the hospital? It's based on your symptoms. If you can cough and get things up, that's great. If you can breathe and don't need oxygen, that's great. If you can control your fevers, that's great. Stay home. Ask your doctor when you call, and he's going to ask you through a bunch of questions, because basically what they do in the hospital is they just support you through the time that you're eradicating the virus. And they're going to keep you breathing. They're going to keep your fever down. You're going to keep your secretions out. So if you can manage to do all that at home, great. If you need the support in the hospital, then you got to go to the hospital. Will Plex make you more able to fight COVID infection? Plex is very short-acting. So if you've had Plex very recently, yes, I suppose it can. But you remake all of your antibodies within a couple weeks, and so you should be okay. If you've had Plex more than 2-3 weeks ago, your immune system should be back on track. Okay, I've had 2 serious attacks as a result of H1N1 and flu vaccines, with the COVID vaccine being more like the flu vaccine or like Tdap. Tdap is tetanus, diphtheria, and pertussis. Those are live viruses that are then killed. So they're not live viruses. By the time you get them, they're already killed. They cannot replicate in your body, but they're the whole virus. And so your immune system takes up the whole virus and tries to make an immune response to the whole thing. It's thought to be even more protective than if you get a little piece of the virus to make an immune response to. So Tdap is a very, very effective virus, but it's very immune activating. Flu vaccine is recombinant. It's one protein, so you produce one defense against the flu virus, and hopefully when the CDC goes to China and picks the strains of flu to make the vaccines for that year, they pick the right ones. Because if they pick the wrong ones, you can still get the flu virus even if you get the vaccine. Now this COVID-2 does not mutate a lot. This COVID-19 virus that they isolated in Italy and China is almost identical. And so if they make a vaccine to it and it's effective, then it should be effective to it worldwide. And it should be a recombinant protein, so that's among the safest types of approaches. Would your immune systems be more or less likely at risk getting to your next infusion? When you're on Rituximab, you keep your B cells at 0. That's the goal. And when you get your next dose of Rituximab, your immune system should not be getting stronger. It should still be 0. And you get your next dose to keep it at 0, not to bring it back down to 0. So if you're on a regular schedule for Rituximab, you are keeping your immune system at the same level at all times, all year long, by keeping your infusion schedule. If you're the type of person who gets your Rituximab when you need it, so say at month 7, month 8, month 9, you try to stretch it out, then your immune system starts to come back up. Your B cells are detectable. That's when you want to go get your infusion, and then your immune system is suppressed again after your next dose of Rituximab. Then if you're that type of Rituximab patient, then your immune system gets a little stronger and then gets suppressed again with Rituximab. The idea is, while it's getting a little stronger, maybe it's a little stronger to fight COVID, but like I said, with Rituximab, we don't really know that it's that immune suppressing. Okay, you have a guide dog. I'm concerned about your dog touching something and getting infected. I think I saw a news article about one dog carrying the virus. I don't think that this virus would survive very long on the fur coat of a dog. It does survive for up to hours on a solid surface like cardboard, for example, 24 hours, or steel even longer. But on the fur coat of a dog, I don't think it's going to last very long. So let's say a COVID-19 infected person sneezes on your dog, sneezes on his hand, pets your dog. How likely is it that you'll get the infection? I don't think it's very likely that the virus will last very long on the fur coat of a dog. Should pediatric patients stop immunizations to avoid exposure? So if your child is getting regular vaccines, my assumption is that is routine care that's going to be deferred. If your child is going in for a doctor visit and they want to give a routine vaccine, so you're 4 years old and you've got your set of vaccines to do, you can do them. They don't make you any more or less susceptible to COVID-19. But again, if you don't need to be at a doctor's office where there are people coughing up virus, try to defer your visit unless you need to be there. I just got word that about 2 NMO patients in South Florida with 2 positive COVID-19 testing. One seems to be recovering. We'll need to hear about 2 others, or about another person. So please do keep us informed. This will be very helpful to us to be able to advise other people. Okay, let's see. Other questions? We're already at just a few minutes after 1, so I'll just take 1 or 2 more questions. Okay, what about Actemra? Actemra is tocilizumab. And tocilizumab is being used widely to prevent cytokine storms in lots of settings, including COVID-19. If you're getting tocilizumab, it's fine to continue to get tocilizumab. That's totally fine. And then medications to suppress cough. If you need it to help control your secretions, that's fine. You can take it. You don't need to cough all the time, make yourself miserable. Even if you have the infection, as long as you're controlling your secretions and you're getting things up and not harboring them in your lung, then you should be fine. And then last question, what I mean spray down your groceries. I just mean if you have a loved one who's interacting in the grocery store or at work and bring home lots of virus and you're worried about bringing something home, you can always spray down your groceries. These are people who take a mild bleach spray or Windex and wipe everything down. That might be overkill, but people do that for their boxes that they receive in the mail from Amazon and other places. If you really want to do that, that would be the strongest precautions you could take. If you're like that 68-year-old lady who had every risk factor in the book, that might be something you want to do. If you're just on rituximab, you may not need to do that. Okay, so wow, I do appreciate there are quite a few more questions. Maybe I'll take them all offline if you post them on Sumaira's website or on our NMO Clinic website. I do want to thank everybody for logging in. I appreciate the chance to have this conversation with you all, and I hope to talk to you again soon. Take care, everybody.